I think that's right. We're gonna be precise. Okay. Good morning, everyone. We're going to go ahead and get started, be respectful of everyone's time. It's my pleasure to introduce Dr. Sassine. Actually, I think I might be pronouncing it wrong. He received his medical degree from the Lebanese American University School of Medicine in Lebanon, and he subsequently completed residency in internal medicine at the Icahn School of Medicine at Mount Sinai, St. Luke's Roosevelt Hospital Center in New York, where he served as chief resident. He subsequently pursued a fellowship in infectious disease immunocompromised track at the University of Texas Health Science Center and MD Anderson Cancer Center in Houston, Texas, where he also served as chief fellow. He's currently an assistant professor of medicine at the infectious disease section in the University of Oklahoma Health Sciences Center, which he joined in July 2021, and currently serves as an associate program director of the ID Fellowship Program. His research interests include infections in patients with hematological malignancies, including hematopoietic stem cell transplant and CAR T cell therapy. So, we really became interested because of his publication track record at such an early stage in his career, and also because of our own growth in the HEMON program and introduction of CAR T therapy soon to come. So this is information that's going to be really important to all of us, and we're very much looking forward to your talk. And we appreciate you traveling here to Safety. Welcome.
Well, thank you for the introduction. Thank you for having me. So we're going to get started. Today's talk will be about infections after CAR T cell therapy. And these are my conflict of interest disclosures, none of which are directly related to this talk. And by the end of the session, we will have reviewed the basics of CAR T cell therapy and its complications, identify risk factors for infectious complications, and then describe the incidence and types of infections based on the available literature. So this is the outline. The first part, maybe the first 15-20 minutes, we're going to talk a little bit about the basics of what CAR T cell therapy is, what are its immediate hematological complications. And I'm going to start with a disclaimer that I'm not a hematologist-oncologist, even though I'm married to one. But to take this with a grain of salt, this is a bit more geared from the ID perspective. So what are the chimeric antigen receptors? These are engineered receptors that will graft a defined specificity onto an immune effector cell, such as a T cell, or an NK cell in the case of some experimental products we currently have. And essentially, the goal is to augment its function against tumor cells. The very early generation chimeric antigen receptors had a T cell activating domain and then an extracellular immunoglobulin-derived heavy end light chain to direct specificity. The second generation chimeric antigen receptors and onwards added a co-stimulatory receptor, again, to very closely, I'm going to try to use the pointer here, but to very closely resemble the native T cell receptor. And co-stimulatory receptor, just like in your native cells, will enhance proliferation of the T cells and their anti-apoptotic function and will allow direct expansion of the cells in vivo. And this is why we like to call them persistent living drugs, meaning you infuse the cells and then they actually stay in the patient's body. So what happens to the patient when you infuse? First, you give the cell infusion. Those cells will engraft and then will undergo extensive proliferation in vivo, and then will go recognize tumor cells and will start killing them. And again, because they persist, they can actually help perform immune surveillance to prevent recurrence of disease. They can contribute by releasing antigen, by assisting tumor-infiltrating lymphocytes, and just by persisting in the tissue. This is a list of all the FDA-approved CAR T-cell products. And today in the talk, we're going to be covering FDA-approved products or infectious complications of FDA-approved products. There are experimental products that are still in clinical trials for which we still do not have a lot of data, although sometimes you occasionally see those patients. And I want to say two notes on this. The first one is that all of these products are autologous, meaning the cells are coming from the patient. These are not allogeneic products. There are allogeneic products that are under investigation. The second note here is that of these 7 approved products, 5 of them are targeted against CD19. So these are CAR T cells that will specifically recognize the CD19 receptor on the surface of tumor cells. And as you can imagine, these target B-cell-related malignancies, so BALL, and then certain types of non-Hodgkin's lymphoma. There are 2 products that are BCMA targeted, and these will target the BCMA receptor on the surface of myeloma cells. So these are myeloma products. Obviously, the product name and the brand names are very complicated. Now, what happens behind the scenes, again, remember, this is an autologous product, so the cells are actually collected from the patient by apheresis. They are taken to the quote-unquote lab where they are transduced with a retroviral or a lentiviral vector that encodes for that chimeric antigen receptor. Here in this example is CD19, it could be BCMA, it could be really anything. And this will insert a copy of the DNA into the T-cell genome. And then they undergo ex vivo expansion and purification, testing for quality and sterility. They get cryopreserved and then shipped back to the hospital. And this entire process takes 2 to 4 weeks. Now, remember what I just said here. The T cells get transduced by a retroviral vector. This brings up an interesting ID question. This was the case at MD Anderson, actually, in 2017. They had a patient with follicular lymphoma who got CAR T, and there was a plan to undergo a consolidation with a stem cell transplant 2 months later. They do the pre-transplant screening, which is a qualitative nucleic acid amplification test for HIV, and it came back positive. And the patient did not really have any risk factors. They do a quantitative RNA test, and it comes back at 74 copies per ml. The 4th generation HIV screen is negative, and the patient's CD4 count was good. So they contact the manufacturer of the CAR T cells, and it turns out this product was created using a lentiviral vector, which contained HIV gene sequences, including LTR and GAG. And if you look here on table 1, one of the most commonly used HIV nucleic acid amplification assays is the Roche assay, and these are the 2 targets. This was another case series and review of the literature from Sloan Kettering a little later, where there have been a few false positive tests here. So keep that in mind. If you do a qualitative screen after CAR T, it's possible that something might be positive. Just an interesting ID tidbit here. So switch back to hematology now. So what happens to the patient in the meantime while those cells are getting prepared? Some patients actually receive bridging chemotherapy. The decision is really the hematologist's decision based on the state of their disease. They typically receive this after apheresis, and the goal is for the disease to be stabilized while the CAR T cells are being prepared. And then once these cells are available, the patient typically is contacted or scheduled to receive what we call lymphodepleting chemotherapy. The most common regimen nowadays is fludarabine and cyclophosphamide. This is typically administered 3 to 5 days before CAR T cell infusion. And the goal here is to deplete the patient from their own native T, B, and NK cells so that there's a favorable environment for the CAR T cells to expand in vivo. And then we like to call the day of cell infusion day 0, a little bit like in bone marrow transplant. So the next part here, we're going to talk about complications of CAR T cell infection, complications of CAR T cell therapy, which are also the risk factor for infection. And This is a list of those complications that can be divided into two parts. Early complications, and we will cover CRS, ICANS, HLH, and cytopenias. And then late complications, the big one being B-cell aplasia and hypogammaglobulinemia. We're going to talk a little bit about prolonged cytopenias under cytopenia. The ones we will not touch upon today are late neurological events, late immune-related effects, and then subsequent malignancies. And there have been increasing reports of MDS happening a month to years after CAR-T. So we'll start with CRS. CRS is a cytokine release syndrome, which is typically triggered by activation of the T cells when they engage their chimeric antigen receptors with tumor antigens. And think of it like any cytokine storm. So there's going to be a massive release of cytokines and chemokines, particularly interleukin-6, interferon gamma, interleukin-2, and then this will activate bystander immune cells to release more interleukin-6, and then it's a cytokine party. Typically, this is a very early complication that typically peaks 2 to 7 days after infusion. We can see it up to 3, rarely 4 weeks. And the incidence varies depending on the product. Some products can have an incidence of up to 70–80%. And then obviously it's a cytokine storm, so any organ system can be involved. And this is going to be a very common ID consult because these patients are neutropenic and they are febrile. And what do we do? Is this an infection or is it CRS? Right in 2025, we do not have a test that can distinguish them. So you often end up treating both. There is standardized grading for CRS depending on fever, blood pressure, oxygen requirements, and based on the grade, which can go from 1 to 4, this decides one, where the patient is cared for, whether they can be cared for on the floor or in the ICU. And then this also dictates therapy. The first line treatment for CRS is an anti-interleukin-6 monoclonal antibody called tocilizumab. For refractory CRS, they can add steroids. There's more data nowadays on using anakinra, which is an anti-interleukin-1. So we see that often with tocilizumab. Typically, most patients are going to require maybe 1, maximum 2 doses of tocilizumab. But keep in mind that tocilizumab can increase certain forms of infection. Mind you, most of this data is really from rheumatological diseases where they use tocilizumab chronically. And so with that, with cumulative dosing, there is cumulative immunosuppression. And these are the things to consider when using tocilizumab, especially at frequent doses or higher doses. TB, endemic fungal infections, strongy, herpes zoster, hepatitis B or C. We screen for most of these pre-CAR-T anyway. It can also delay wound healing, and it has been associated with GI perforation or diverticulitis. The next complication is more it's called ICANS, and that stands for immune effector cell-associated neurotoxicity syndrome. There are 2 possible pathophysiological mechanisms for ICANS to happen. One is either passive diffusion of those cytokines into the brain or active trafficking of the T cells into the CNS. Also happens early at the median time of 4 days after infusion, and the incidence, again, varies by product. One of the diagnostic criteria for ICANS is something called the I-score. Think of it as like a modified version of a mini-mental exam that typically the hematology teams perform on a daily basis on the patients. And then based on the I-score, the mental status of the patient, if there is presence or absence of seizure, a presence or absence of cerebral edema, this determines the grade of ICANS. And again, this determines what therapy they receive and where they receive it. Obviously, grade 3 or higher ICANS, they end up in the ICU. And then treatment typically is dexamethasone is the first line. For refractory ICANS, you know, there's a good saying, we have an idea, if it doesn't work, double the dose. So they get more steroids. And they can also sometimes administer tocilizumab, anakinra, and others. There's always also question that comes to the ID service in settings of severe ICANS is, should we do lumbar puncture? Is this a CNS infection? And again, there is no good test for that. And again, it depends on the patient. Some patients respond very quickly to steroids, so you know right away this is ICANS. For some other patients, especially when it's refractory ICANS, you end up having to do an LP to rule out a herpes virus reactivation mostly. The next complication is HLH, and think of it as a CRS gone wild. So that's like the extreme spectrum of CRS. You can end up with hemophagocytic lymphohistiocytosis, a very low incidence, and the diagnostic criteria essentially are a little bit adapted, but really the things you think of with HLH. And the management here typically is going to be manage them for CRS. If they do not improve after 48 hours and you have a good suspicion for HLH, then you can consider adding etoposide. You can consider adding kind of more HLH-directed therapies. The next complication is going to be cytopenias. And initially, you know, in the early days of CAR T, a lot of these patients came in after 6, 7, 8 lines of cancer therapy. So a lot of them came in with baseline cytopenias. We don't see this much up front nowadays because we're using CAR T in earlier lines as second, third line. So, but there's potentially some patients who will walk into CAR T already cytopenic. Obviously, everybody's getting lymphodepleting chemotherapy. So on the day of cell infusion, everybody's going to be cytopenic. And then typically in the first 2 to 3 weeks, this is when patients will recover their counts, except that some of them don't. This is a very early study here, published in 2021 from MD Anderson, patients with refractory large B-cell lymphoma who got axi-cel, which is one of the CD19 products. And at day 30, about half of the patients still had grade 3 or 4 cytopenias. And then the predictors of that were really poor performance status, more than 3 prior therapies, and then low lymphocyte count at baseline. And then when they followed these patients at 1 year and 2 years, for those patients who still were in remission, 27% of the patients still had grade 3 or 4 cytopenia at 1 year and 11% at 2 years. So it does get better, although there conceivably is a small subset of patients who will still have cytopenias for a long period of time. All patients recovered their CD8 T cells and their NK cells at the 1 year. About 2/3 recovered their CD4 count at the 1 year mark. And in that cohort of 31 patients, they actually had 4 cases of MDS at a median of about a little over a year. So typically one recommendation is, you know, if your patient is persistently cytopenic at the 1 year mark, you should look for MDS, of course. And this is over time how these cell counts recovered. And in the lower part, they do demonstrate a correlation between the platelet count and the NK cell count. So platelet count is a good proxy for that. Now, within the big topic of cytopenia, one is a big problem in CAR T is actually B-cell aplasia. And the reason for that is, as I mentioned, the current products that we have, some of them target CD19, some of them target BCMA. And yeah, the technology is very cool, but the cells cannot distinguish a CD19 on a tumor cell or a CD19 on a healthy B cell. So the CD19 receptor, just like it is expressed on lymphoma cells, it is also expressed on precursor B cells all the way through memory B cells. But it's not expressed on those long-lived antibody-producing plasma cells. Meanwhile, BCMA, which is the target for the myeloma product, again, found on myeloma cells, but is also expressed on the late-stage memory B cells and then on the long-lived plasma cells. So this is here what we call an on-target, because it's really hitting its target, but off-tumor effect of the CAR T. And so the extent of B-cell aplasia and subsequent hypogammaglobulinemia will depend on the CAR T product and on its target. I'll take a second with this graph here on the right side. As you can see, the upper part looks at CD19. And with CD19, what you will see is a drop in the total immunoglobulin G level. But because those long-lived antibody-producing plasma cells are not targeted, their pathogen-specific antibodies are going to be preserved. We do not see that with BCMA products because it really targets the plasma cells. So to get a measure of the extent of the issue, at 1 month, more than 85% of the patients will have B-cell aplasia. At 1 year is about half of the patients. And then when they did bone marrow biopsies after CD19, again, there were some BCMA plasma cells still present, whereas after BCMA CAR-T, all the plasma cell populations are depleted, so you see more severe antibody deficiencies. Keep in mind that we use some CD19 products for B-cell ALL. Most of these patients are kids, and in kids, they do not have established plasma cell clones as good as adults. So you will see more profound B-cell aplasia, more profound hypogammaglobulinemia in kids receiving CD19 products over adults receiving the same CD19 product. So hypogammaglobulinemia, again, some patients can walk in to CAR-T with hypogammaglobulinemia. Those who have received 7 lines of therapy, 6 of which include rituximab. This is where you're going to see that. Patients with multiple myeloma tend to have more hypogammaglobulinemia at baseline. And then when they looked at this over time, typically the nadir of hypogammaglobulinemia is about 6 months. And about 1 year, maybe about half of the patients still had hypogammaglobulinemia without immunoglobulin replacement therapy. This was for Axicell. Other products in their early phase trials had lower rates of hypogammaglobulinemia. So again, it's patient-specific, product-specific. In pediatric B-cell ALL patients, there was really prolonged B-cell aplasia. 2/3 of the patients at 12 and 24 months reported for over 5 years. And then in BCMA CAR-T, again, about 70% of the patients had it in the first 3 months, and then at 1 year, about 40%. Now, this is all IgG. We have very limited data on IgA or IgM. It's very common to have low levels to begin with, especially if your patient has received an anti-CD20. Where they can be helpful is if you are giving your patient the IVIG, measuring the IgA and IgM levels, because this does not get affected by IVIG that much, can be a good surrogate marker for immune reconstitution. So here, coming back to this concept that you have total hypogammaglobulinemia, that is a problem for both CD19 and BCMA products. Pathogen-specific antibodies, meaning when you're looking, say, at anti-measles IgG. This seems to be more of a problem with BCMA. There are some gaps in strep pneumo and Haemophilus influenza type B, even in CD19, and patients who receive CD19 patients. But since they typically receive trimsulfa for pneumocystis prophylaxis for at least the first 6 months, this kind of covers those gaps in seroprotection. And so this is the kind of a study from Fred Hutch, where they looked at 22 patients who received CD19 CAR-T, and they looked at measles-specific IgG concentration. And really, they only had 1 patient who was seropositive before CAR-T, and then they lost their seroprotection post-CAR-T. And this was someone who had a prior allogeneic transplant, so already at a high immunological risk. So this is kind of a little suggested framework from the Fred Hutch group on how to approach immunoglobulin replacement therapy in those patients. Typically, in the first 3 months, really anyone with an IgG level less than 400 probably needs to get IVIG. Beyond the 3-month mark, if you're a pediatric CD19 CAR-T cell recipient or BCMA CAR-T cell recipient, soft recommendation to maintain IgG levels above 400, regardless of whether they develop infections or not. In adults receiving CD19 product, after 3 months, it's really both having an IgG level less than 400 and having recurrent or serious bacterial infections. And these are the patients who would theoretically benefit more from IVIG replacement. So to put it all together, when we assess one of a CAR T cell recipient on the ID service, these are all the things we look at. We look at where are they coming from in terms of cancer treatment, what were their prior lines of therapy, how close we are to lymphodepletion and to the CAR T cell infusion. Did they develop CRS? What did they need for that? Did they develop ICANS? How long have they been on steroids for that? And we try to look at some of their kind of basic immunological markers. Are they neutropenic? Are they lymphopenic? Do they have hypogammaglobulinemia? Are they still in kind of the pre-neutrophil recovery timeline, or have they recovered their neutrophils already? And based on that, we make our decision making. And so this is kind of more detailed about host-related factors, really where are they coming from before CAR T, treatment-related factor, what kind of cells they received, and the adverse events. And then those at really highest risk of infection, those where you have to worry most are those who have received multiple lines of treatment, who have had previous allotransplant, those who have had a recent invasive mold disease, although this might not be a big concern in upstate New York, this is more of a concern for us in the South. Those who walk into CAR T with an active CMV replication, and then again, those requiring a lot of treatments for CRS, ICANS, or those who walk in with baseline neutropenia or lymphopenia. So with that part done, now we're going to move on to talk a little bit about the infections, what kind of infections, what kind of incidents. So again, big problem in hematology clinical trials, they do not report their infectious complications really well. That tell you grade 3 infection, and this could range anywhere from an E. coli bacteremia to an invasive aspergillosis, and those are very, very different for us. But again, this is to say that some products, and depending on the indication they were studied for, will have different rates of infection, particularly high-grade infections, which we saw most of the clinical trials for Cizata and Activa, and then for the BTMA products. This is probably the first study that described infections after CD19 CAR T out of Red Hawks. They had 133 adults who received the CD19 product on a phase 1 or 2 trial, but these products ended up being FDA approved. And they were pretty good in terms of prophylaxis. Everybody has received a bunch of different prophylaxis here, and then they followed them up until day 90. So typically when we look at studies of infection after CAR T, it's important to know what the patient was on in terms of prophylaxis. And so here in the first 28 days, you will see that about 23% of the patients had any infection, and most of these were bacterial infections, very low rate of viral and fungal infection in the first 28 days. And again, most of the infectious events were driven by bacterial infections, half of which were bacteremias, and the others were what we call bacterial site infections, so cellulitis, enterocolitis, etc. A few respiratory viruses, very few fungal infections. This is really, they try to plot out the infection density by underlying disease and then by type of infection. Again, on the left side panel, you see more infections in the first 28 days. Most of these were bacterial. And in the day 29 to 90 days, you are seeing kind of an even spread, although a lot of the infectious events were driven by patients with CLL and ALL rather than lymphoma in their cohort. And then when they tried to look at risk factors for infection within the first 28 days, evaluating pre-CAR T risk factors, patients with ALL had higher risk compared to other disease types, having more than 4 lines of therapy, and then actually having a higher dose of CAR T cells. Then when they looked at post-CAR T cell infusion factors, CRS, ICANS, using tocilizumab and needing ICU admission where the risk factors on their univariate analysis, on their multivariate model, CRS was the only significant variable. They did find, because those patients received different kinds of lymphodepleting chemotherapy, that using Flu/Cy with an optimized CAR T dose had a reduced risk of severe CRS and then subsequently a reduced risk of infection. And this is one of the bases for why we use Flu/Cy. The reason for that is that the other regimens included like 4 to 6 times a higher dose of cyclophosphamide and were thought to be more lymphodepleting. This is out of Sloan Kettering. They looked at 53 adults with ALL, and where most of them received HSV, VZV, fungal, and pneumocystis prophylaxis, again on a phase 1 trial. And the earliest infections that happened were bacterial at a median of 18 days, and these were the most common infections in the early time period. They had a bunch of bloodstream infections, bacterial site infection. The bacterial site infection were mostly driven by C. diff in their cohort. And then in the late stage, the half of the infectious events were respiratory viruses. And they found that CRS grade 3 or more is an independent predictor of infection and an independent predictor of bloodstream infection. And this is how cumulative incidence of infection and cumulative incidence of bloodstream infection varied over time. In blue are the patients who had higher grade CRS, and in red, those who had low grade CRS. And you see that overall infection kind of plateaued at around 60 days, and then bloodstream infections really happened in the first 22 weeks. Now, we're going to move back to the West Coast. So this is looking at late infection, that same cohort we described from Fred Hutch. They followed up 86 patients of the 133 who stayed alive for at least 1 year. 1 out of 6 had prolonged cytopenias, and 2/3 had hypogammaglobulinemia beyond day 90. And this was more of a problem in ALL and CLL. And when they looked at late infections, most of them were upper respiratory infections. Most of them were outpatient infections, did not necessitate inpatient, did not necessitate ICU admission. So only 20% required admission and 5% required an ICU. This is another study. This one is from Sloan Kettering, again looking at late infections. Here there are 60 patients with large B-cell lymphoma who received an FDA-approved product, followed up for 1 year. And you can see the cumulative incidence at 1 year was 63%. Again, in B in red is any bacterial infection. And then in panel C in light green is severe bacterial infection. And you see this really is a big problem in that first month. And after that, it becomes less common. And then in part D is viral infection. And you see this one keeps accumulating up until 6 to 8 months. So again, they had a total of 101 infection events in 40 patients. And then again, day 0 to 30, 2/3 were bacterial. Day 30 and beyond, it was 50-50 between bacterial and viral. They had 1 case of pneumocystis, couple of varicella breakthroughs or VZV breakthroughs on acyclovir. So to put this all together, very concise, in a very concise way, in the early period, in the first 30 days, this is where you have neutropenia, you have mucositis, you have steroids, tocilizumab. You get more invasive bacterial infections, you have a higher incidence, and you have higher severity. In the late period, past 30 days, this is where you're dealing more with hypogammaglobulinemia, with more prolonged T-cell immunity related issues, and you see more respiratory viral infections, you see lower incidence of infections, and you see lower severity. And you tend to treat those as an outpatient. This was all about CD19. What about BCMA products? Data is less available because these are newer products. This is a study out of UCSF in San Francisco. They had 55 patients with myeloma treated with BCMA CAR T, all of whom received appropriate prophylaxis. And you do see here in the upper part that really respiratory viruses are the big problem, and then after that bacterial side infections. And then after that they had some bacteremias. And when you look at how it distributes over time, it seems that day 30 to 100 had more infections than day 0 to 30, although these were mostly driven by mild to moderate infections, both bacterial and viral infection. They really had very few fungal infections, so it's hard to know what that means. And then that same group actually compared myelomas to non-Hodgkin. So they compared BCMA to CD19 CAR-T. It's a bit comparing apples to oranges because these are different patients with different immunological risks. But they did seem to find more bacterial infection in the CD19 group, more viral infection in the BCMA group, for what it's worth. The patients with CD19 tended to have more severe infections and tended to have more bloodstream and GI infections. And then there are risk factors for infection were use of steroids and then post-CAR-T hypogammaglobulinemia. So again, nothing groundbreaking. So for the next 20 minutes or so, we're gonna take a focus on two groups of opportunistic infections, fungal infections and then herpes viruses. So with fungal infections, this is a review paper from 2021, compilation of all the fungal infections that were seen to date in after CAR-T. So I'm going to walk you through the big patterns here. The first slide is about invasive yeast infections, and as you can see, those were mostly candidas. In the patients who did not receive any antifungal prophylaxis, we saw candida albicans, which is very acceptable. And then in the patients who received fluconazole prophylaxis, we saw the candida species that are fluconazole resistant, primarily glabrata. Most of these infections happened in the first 30 days, and then about half of these patients had CRS and required TOCI, half of them had a prior transplant, and very few patients died because of this fungal infection. When you're looking at mold infection, again, most of these patients were on either an echinocandin or an azole, and then the big driver here was, was aspergillus. Also happened. Some happened early, some happened past day 30, and those tended to be a little bit more fatal. Most of these infections happened in patients with ALL or CLL. Very few pneumocystis, because again, most centers, even in clinical trials, were giving pneumocystis prophylaxis, and these were on either patients who completed their prophylaxis or who were non-compliant. So that's kind of the big picture back in 2021. And so this group who wrote the paper tried to identify two high-risk profiles for mold infections. The first type of patient is those with prolonged neutropenia, and those look a little bit like your patients with AML. And then the other profile is those who are receiving steroids or other immunosuppressants, and these look more like your patients with GVHD. And they suggested that it would be preferred for these patients to be on a mold-active prophylaxis, such as posaconazole. However, antifungal prophylaxis in CAR-T has not been studied prospectively like it has for AML or for bone marrow transplant, so we don't have good confidence in those recommendations. Last year, the ASTCT released kind of a best practice guidance, and that tells you a little bit what the level of evidence is. They did not call it a guideline on how to prevent infections after CAR-T, and that starting with lymphodepletion therapy and until their ANC recovered, that you give them a yeast-active prophylaxis like fluconazole or an echinocandin, and that patients should receive pneumocystis prophylaxis up until 6 months post-CAR-T, at least 6 months. And then they did have a mention saying consider mold-active azole prophylaxis in patients who have had prior allotransplant, prolonged neutropenia, or steroid therapy for CAR-T-related toxicity, or who have a recent history of mold infection. Some of these are self-evident. This is a recent paper that we published. We took this large database called TriNetX, and we tried to look at certain types of infections after CAR T. So again, this is limited by being a large database analysis, but we had over 2,000 patients. So this is the largest study of infections after CAR T to date. About 80% were CD19, 20% were BCMA CAR T. And we looked at fungal infections, herpesviruses, and then respiratory viral infections. And we'll come back to herpesviruses in a bit, but if you look at the fungal infections, about 40% of the fungal infections in that cohort really occurred on day 0 to 13, and then the rest evenly spread out even beyond 1 year. About 11% of the patients had the fungal infection. This was mostly driven by Candida infections. 2% of the patients had Aspergillus infections, 1% had pneumocystis, and then the rest were below 1%. Candida infections tended to happen earlier than Aspergillus or pneumocystis in terms of timing. And when we tried to look at what predicted fungal infections in these patients, prior hematopoietic cell transplant, CRS, hypogammaglobulinemia, receiving certain drugs such as cytarabine or etoposide were associated with that. Caveat is the database included both mucocutaneous and invasive candidiasis. But another thing we learned is that there's a very low incidence of mold or pneumocystis infections, despite very high rates of glucocorticoid use. About 91% of the patients got steroids after CAR T, and half of the patients had CRS. And there was very low use of mold-active azoles, and about actually 50-something% of the patients did not use Crimsolva. So, this is the meta-analysis done by one of my resident mentees. She's presenting it in an upcoming conference, but we looked at 17 studies, specifically looking at pneumocystis after CAR T. Had about 2,000 patients. The pooled incidence of pneumocystis was about 1%. About a third of those events happened in day 30 to 180. Most of those events happened after day 180, which is typically the 6-month mark, after which most patients stop prophylaxis. And even though it was rare, you'll tell me, okay, 1% incidence is low, but the pooled mortality among patients with pneumocystis is 22%. Now, this is not specific pneumocystis-related mortality, but this can tell you something about the patient's immunological status. Now, we do all this talk about fungal infections, but as you probably know already, fungal infections really depend on geography. And so this here is a retrospective cohort of CD19 CAR T, mostly lymphoma. So keep in mind there are not a lot of patients with leukemia, mostly lymphoma. And this is from Dana-Farber in Boston. They had 280 patients. They did not give anybody any candida or any mold prophylaxis. So no azole, no echinocandin. 3% of their patients developed probable or proven fungal disease after CAR T. They had 2 invasive candidiasis before day 100, 3 invasive mold infections before day 100, and then 3 patients with pneumocystis after day 100, one of whom was non-compliant with prophylaxis, and then 2 were past the 1 year, so past any prophylaxis recommendation. And so despite high rates of CRS, ICANS, neutropenia, hypogammaglobulinemia, and then low CD4, so despite all of these risk factors, so I think the risk depends mostly on underlying disease. Again, they had few patients with leukemia here, but then also on geographical location. Down in Oklahoma, I cannot afford to do that. But the group at Sloan Kettering, this was recently published maybe a month or 2 ago, took this a bit further. So they studied a retrospective cohort of CD19 CAR T patients for B-cell lymphoma. They had 330 patients. They split them into 2 groups. The first group was from 2016 to 2020, where everybody got fluconazole until they recovered their ANC. The second group was from 2020 to 2023, where what they did is they identified those 3 high-risk patients, prolonged neutropenia for 3 or more weeks, systemic steroids for 3 or more days, or previous invasive fungal infection, and those patients got a mold-active azole prophylaxis until they recovered their ANC. Everybody else did not get anything. If patients had drug interactions or LFT abnormalities in either groups, they received micafungin. Everyone received 6 months of pneumocystis prophylaxis. They even extended it further for those who had lymphopenia. About half of the patients had CRS and 1/5 had ICANS. And so in the first group, 84% ended up receiving antifungal prophylaxis, mostly fluconazole. Only 5% received antimold prophylaxis. They had one case of CNS cryptococcal. In the second group, you see only a third of the patients received antifungal prophylaxis, but about 11% received antimold prophylaxis. And they had one case of related aspergillosis, and both these patients were on an echinocandin. Again, this was limited to CD19 CAR T for B-cell lymphoma. We have to keep in mind then that these are not contemporaneous groups. There was a big evolution in standard practice over time, both on the hematology side and on the ID side. So this is another limitation of the study. But this brings up the question, should we individualize antifungal prophylaxis to avoid toxicities, drug interactions, financial toxicity, and can we do that without increasing the risk of invasive fungal infections? So remains to be studied. The next part is my favorite, herpes viruses. So this is again the same large database analysis. We also looked at herpes viruses. And again, as you can see here in red, most of these infections, about 40% of them happen in the first 30 days and then evenly spread out after that. About 14% of the patients had a herpes virus reactivation, happened early on at the median of 70 days, mostly driven by CMV. And then when we looked at risk factors for herpes virus infections, again, prior transplant, ICANS, hypogammaglobulinemia, rituximab, and anakinra were the independent predictors. There was very low incidence of HSV-VZV, as you can see here, less than 2% each, due to widespread use of prophylaxis. There are about 2.5% of the patients who carried a diagnosis of HHV6 or who had a positive HHV6 PCR. We don't really know what this means. HHV6 encephalitis is extremely rare after CAR T. This is a recent review that we published a couple months ago looking at herpes viruses after CAR T, and this is kind of a summary of all the studies that evaluate the CMV after CAR T. And as you can see here on this column, about I would say 25 to 30% of the patients will have any kind of CMV reactivation. But then when we look at what we call clinically significant CMV infection, which is a composite outcome adding the CMV and organ disease and CMV DNA requiring antiviral therapy, I think the number is at about 3%. Very rare cases of CMV and organ disease. In the biggest cohort that we published out of MD Anderson, the rate was 3% for CMV. And this is actually that study we worked on during my fellowship. We had 230 patients with CD19 CAR T cell therapy at MD Anderson. 22% of the patients had any CMV reactivation, and then 10% had clinically significant CMV infection. Occurred early on, median of 17 days after CAR T, and about a third of those patients, so 3%, had CMV and organ disease. And the independent risk factor for clinically significant CMV infection was Asian or Middle Eastern, and then treatment of CRS or ICANS with steroids. We also found that having clinically significant CMV infection within the first year post-CAR T was associated with a higher risk of non-relapse mortality, odds ratio of 2.5, despite having a low rate of CMV and organ disease. So this was not really direct effect of CMV infection. This was more what we call the indirect effect of CMV. It is an immunomodulatory virus. I think the last study we're going to talk about is this. This is out of Fred Hutch, published last year. This is the only prospective study looking at CMV after CAR T. They had 72 CMV seropositive CAR T cell recipients who got prospective weekly follow-up, and then they got a CMV-specific T cell immunity assay at pre-CAR T, so that's baseline week 2 and week 4. Again, they had about 10% of the patients reach the viral threshold in their institutional protocols. So that's the clinically significant CMV infection. They did not have any patients. And the big finding from this study is that if you look at the ID1 or CD65 spot, which are the two antigens we look at when evaluating CMV-specific T-cell immunity, most patients get their CMV-cell-mediated immunity at about 2 weeks post-CAR T, and then most of the patients recover this at the 4-week mark. And again, this is consistent with when we've seen CMV reactivations after CAR T. The risk factors for CMV reactivation in this cohort were BCMA CAR T over CD19 for whatever reason, and then receiving steroids more than 3 days, which makes sense. So, summary of CMV after CAR T. Clinically significant CMV infections affect about 10% of the patients, and organ disease is rare. Most will occur early, coinciding with a dip in CMV-specific cell-mediated immunity. The highest risk are going to be those patients with CRS or ICANS requiring steroids, maybe those receiving BCMA over CD19. We probably should consider CMV monitoring for those high-risk patients in the first 2 to 6 weeks. There is an association with non-relapse mortality, perhaps it has to do with the indirect effect of CMV. We still need prospective studies with systematic CMV monitoring to figure out would antiviral prophylaxis affect outcomes in some of these patients that it doesn't in allogeneic transplant. So I'm going to conclude with, since Dr. Reddy told me you guys are starting a CAR T program soon, I wanted to conclude by what we do down in Oklahoma, which is very consistent with the guideline or the best practice guidance from the ASTCT. So we typically offer bacterial prophylaxis with levofloxacin or cefpodoxime from day 0 until they recover their neutrophil count. We offer HSV/VZV prophylaxis with valacyclovir from the time of lymphodepletion up until 12 months post-CAR T. For CMV, we do not offer prophylaxis. There's no data for that, but we currently do weekly plasma PCR in those with prolonged neutropenia, those with grade 3 or 4 CRS or ICANS, and those on steroids until 30 days after the last steroid dose. We do offer yeast-active prophylaxis with fluconazole or micafungin from lymphodepletion and until they recover their ANC. And then for a subset of patients, which we call high risk, we offer mold-active prophylaxis with POSA or ISAVU. And we offer that from the moment the high risk is established until resolution of neutropenia or completion of steroids. And these patients are going to be prolonged neutropenia more than 2 weeks, steroids more than 1 mg per kg per day for more than 3 days, prior mold infection, recent allotransplant for those patients with leukemia. And then we offer pneumocystis prophylaxis with trimsulfa or IV pentamidine from day 28 up until 6 months post-CAR T. So last slide, what else is needed in terms of literature in that field? I think we need a better understanding of fungal infection risk and individualized prophylaxis strategy, including mold, but also including pneumocystis. Should everyone stop at 6 months, or there are patients who need longer than 6 months? I think we need improved antimicrobial stewardship in the immediate post-CAR T period, this first 30-day period, how to distinguish CRS from infection, how to distinguish ICANS from infection. We need a better understanding of immune reconstitution after CAR T, because it has implications on infection surveillance, prophylaxis, immunizations. I did not even talk about immunizations here, because it's a whole separate topic. And the one-liner I'll say about this is, right now, we don't have CAR T-specific data on immunization, so we extrapolate from hematopoietic cell transplant, and we put them on the same immunization schedule. And then we also need more data to determine infection risk in new or investigational CAR T or CAR NK products. There's CAR T upcoming for solid tumors, hematological diseases. There's allogeneic off-the-shelf CAR T for hematological diseases, and we don't really know a lot about these products. So any questions, comments? Yeah.
You said you started levofloxacin in basic. So if these patients spike after that, you continue with levofloxacin or you switch them?
Okay, I'm going to repeat your question first for this one. So the question was, for bacterial prophylaxis, we start levofloxacin at day 0. If they have a fever after that, what do we do? We typically treat it as a prophetic fever, so we switch them to an ID, which is the one that I or the flying Sassine, and we work them up for prophetic fever. So blood cultures, respiratory panel, chest X-rays are basic workup, and then obviously a lot of times we end up getting involved in ID and we work them up further depending on the story. But if they break through a fever on levofloxacin, we switch them to and sometimes we even add vancomycin upfront, depending again on the situation. So that same process you would follow for neutropenic fever. Yes.
By data on the impact of geography on the fungal infection. What's your hypothesis underlying the mechanism?
Sure. Sure. So the question was about the geography of fungal infections. This is not really a CAR-T-specific issue. This is just really all fungal infections, both what we call the endemic mycosis, so think of histoplasma, blastomyces, coccidioides, but then also the mold infections have geographical distribution. I think the big driver here is the climate. Obviously, it's the temperature is in the high 70s in Oklahoma today, whereas here it's in the low 30s. So the climate is different between different parts of the U.S. Down in the south, we have warmer climate, we have more humidity, which also means patients tend to spend more time outdoors, so they have more opportunities to inhale all these fungal spores from an environment that is more favorable for these fungal spores to germinate. So I cannot afford to have a patient who's neutropenic on fluconazole. I know it's a matter of time before they get a fungal pneumonia, whereas here it might be different. So I think that's really the big driver. Yes. Yeah, I think it's both. So the question was about why we think CRS is a risk factor for infection, and is it confounded by the treatment? I think treatment of CRS is a big driver of that, but even in multivariate models that have controlled for the treatment, high-grade CRS in and by itself was independently associated with more infections. And I think some of it has to do with just the pure systemic inflammatory nature of the syndrome. You potentially see more mucositis. You see, if you have high-grade CRS, you're more likely to go to the ICU. You're more likely to keep a central line for longer. Probably your neutrophils are going to take a little bit more time to come back. So all of these kind of compound that risk of infection.
I was curious a little bit about the general efficacy of, I mean, obviously these are different disease states, right? But are there time points, general time points where you're expecting to see a good or a poor clinical response in terms of the hematologic malignancy, and how I'm assuming that if you're seeing a poor response, that's going to play into your infection risk as well.
Correct. Now, again, I'll thread this very carefully because I'm not a hematologist and there might be people in the audience who can answer this better. But my understanding is I think at around the day 28 and then probably at around 3 months is where they restage the disease. Obviously, if there's good response, great. But yeah, I have seen, I mean, I recently had a patient on service who had CAR-T and had no response at all, compounded by the fact that he also never recovered his neutrophils and he got disseminated fusariosis. So and now we're in a place where he doesn't have neutrophils. He has no lines of therapy left for lymphoma, and we have to deal with all the infections. So you're right in the sense that if they don't respond to CAR-T, it's going to depend a little bit on where they're coming from in terms of their disease. Do they have other treatment options available? If they have other treatment options available, that means they will get more immunosuppressed, so you're gonna have different types of infections to expect. If they do not have options left, that means typically this is someone who has exhausted all of their lines. The patient I gave you an example, I just mentioned is someone who had 6, 7 lines for lymphoma, had an allotransplant for lymphoma, relapsed after an allotransplant, received one of the newer therapies, bispecific antibodies, or received a BiTE for lymphoma, relapsed after that, and now did not respond to CAR T. So if they don't have lines of therapy left, this is also going to be a big risk of infection because they're in pretty bad immunological shape. Thank you.
There was nothing online, right?
Okay.
Cool.